Good morning, guys. I hope we're all sparkly. Well, we're a little bit wet actually. It's raining. However, thanks to Through Dark, I'm dry underneath. Anyway, let's talk about what my favorite topic, microdosing TRT, using the minimum effective dose in the correct manner to achieve the desired outcome, stable male androgen levels for long-term physical and psychological well-being. Somebody reached out to me and they said, your microdosing protocol didn't work on me. I took 12.5 milligrams, 100 IU, and I didn't feel any better. What? You took my tailored dose and you thought it would be optimal for you. Are we the same but different? Obviously, we do have similarities, but we're not the same. We're not identical. So your dose is unlikely to be exactly the same as my dose. Oh my word. So I kind of expect that from people self-medicating because they don't understand pharmacokinetics, pharmacodynamics, have a in-depth understanding of physiology, the basics of science, nature. But my colleagues, doctors, I expect more from them. But as is the case, I'm often disappointed. Testosterone cypionate raises hematocrit more than libido. If you inject libido every 12 weeks, 1,000 milligrams, and you recheck your levels at 12 weeks, you will find the hematocrit to be lower than if you inject testosterone cypionate every 3 weeks and measure again in a trough. Okay, yeah, that's basic pharmacokinetics. But if you microdose using the minimum effective dose that mimics physiology, it's not the same thing, is it? At all. You don't get those massive peaks and troughs. You get stable androgen levels. So you don't get an increased rate of erythropoiesis because you're not spiking testosterone to spike the kidneys to release erythropoietin to tell the bone marrow to produce red blood cells. This isn't rocket science, but because there's been no peer-reviewed papers, we're going to go on just the evidence. Now, a good clinician uses the evidence, as in the latest research. He then has to apply it clinically to achieve the best outcome for his patient. Do no harm. And that should be the premise behind every doctor's interaction with their patient. An individual, not a journal, not a textbook. Now, as much as we share similarities, we're all different. Now, in endocrinology, and especially diabetes, if I was diabetic and I told you my insulin regime and you tried that out because we're the same, you're likely to come unstuck, because with excess insulin and you lower your sugar, you actually risk death. Now, there's a trivialization of testosterone's role in physical health, and there's a trivialization in your dose of testosterone to achieve optimal well-being, to feel how you want to feel. But as we said before, we're not all about the feels. We're about normalizing physiology, your blood pressure, your hematocrit, all of the organs that your testosterone feeds. It's a complicated subject, but the premise is very simple. So we know from pharmacokinetics, pharmacodynamics, an understanding of physiology, science, and balance, the need for contrast in order to establish harmony, yin-yang baby, that microdosing TRT makes perfect sense. Daily test SIP and HCG. The HCG mimics luteinizing hormone. It isn't luteinizing hormone, so it won't show up in a blood test. because it's not luteinizing hormone. There's also a little bit of crossover with FSH, but that appears to be genetic, so we can't quantify that. But we know that the HCG and the subsequent stimulation of the LH receptor in the testicles and brain should have a positive outcome. In a small minority of patients, it doesn't. So again, we have to tailor your TRT protocol to you, the individual. And it's very difficult for you to be objective. It's very easy for me to be objective because I've done this thousands of times. Oh, I've dealt with the highs, I've dealt with the lows, and we've eventually got you balanced when you appreciate that you have to look at all the other things. Sleep, nutrition, exercise, work on your parasympathetic nervous system to address stress. I'm finally dialed in. Yeah, I know. Because you've now taken your health seriously. You've had years of abuse through a lack of understanding, a trust in the NHS, who wanted to give you antidepressants and Viagra. You've looked elsewhere. You've taken control of your own health. And you're now sat in front of me wanting to be instantly cured. And the appreciation of the complexity and the necessity for work takes time. And if it didn't take time and it came to you too quickly and too easily, you wouldn't appreciate it. So people say TRT should be free on the NHS. And the answer to that question is yes, it should be. But would you place the significance that it needs to your health if it was free? The number of times as a GP you give a treatment and the patient comes back, says, hasn't worked, didn't take it for long enough, didn't take it properly, didn't look to address the other things that can impact your sense of well-being. The number of times I've counseled a patient for 10 minutes about the fact that they've got a viral sore throat and you need to do X, Y, Z. And at the end of the consultation, they've gone, so you're not going to give me antibiotics? I've just spent 10 minutes trying to explain to you what you can do and why we don't need to give you a medication that has negative consequences and negative effects. Because again, do no harm. The premise behind all therapies should be to mimic physiology or correct an abnormality so that physiology can ensue. And put the work in. Because if you just think taking a tablet is going to cure you, you're severely mistaken. Work, work, work. Because what do you have to do? 8 minutes 15. Earn your reward. So there's really not much else to say, is there? Microdosing TRT. The future of testosterone replacement therapy.